Good morning, and thank you to the Blepharospasm Blepharospasm Research Foundation and to Dr. Michael Yin for inviting me to speak today about the pathogenesis or the causes of benign essential blepharospasm. I have no financial disclosures. As Dr. Ondo mentioned earlier today, benign essential blepharospasms is defined as a focal dystonia characterized by the stereotype, synchronous, episodic, and involuntary contraction of the eyelid muscles leading to closure of the eye. Is a bilateral condition, is usually not associated with any other syndromes. So this is a short video showing a patient with the characteristics of blepharospasms, which you probably are familiar. So what are the type of blepharospasms? We have a primary one in which no organic cause had been identified, and that's the one that we call benign essential blepharospasm. And a secondary means that it's a result of an organic change in the brain. So there are lesions in the brain that can lead to the presence of blepharospasms. And it could be different areas of the brain. It could be the cortex, the cerebellum, the thalamus, pons, and also can develop as a consequence of disease that cause eyelid weakness, such as facial paralysis or myasthenia gravis, a condition that causes weakness of the muscles. And these particular secondary blepharospasm fits the two-factor rodent model for blepharospasms, in which there has to be a combination between the two factors: weakness of the eyelid musculature, but also a loss in the dopamine in the striatal. And that leads to a hyperexcitability of the blinking reflex. Interestingly is that each factor by itself cannot lead to blepharospasm. So, unfortunately, with all the studies have been out there, we still don't know the exact cause of blepharospasms or benign essential blepharospasm. But it's believed to be a multifactorial condition where genetics and environmental factors play a role. So, I'm going to discuss today about risk factors, genetics, neuroimaging findings, functional findings, and pathophysiology. So there's a list of reported risk factors associated with the development of benign essential blepharospasms, and I'm going to go over a few of them. So there is a strong association between eye disease and the development of blepharospasms. In fact, 10% of the patients who have dry eye disease have blepharospasms. And in patients with blepharospasms, even though their eye exam could be normal, they report greediness, foreign body sensation, and dry eye. So as an ophthalmologist, we would like to, first of all, treat the dry eye if we identify that in patients that have like an increased frequency in blinking, to make sure that that is not the cause of the increased blinking, that the dry eye is not the cause. And we would like to condition the eye or improve the condition of the eye before we label the patient as to have blepharospasm or start botulinum toxin, as it could worsen the dry eye in those patients. The other important thing is that in patients who start with increased blinking, they can have dry eye, and that can precede the development of the blepharospasms in the future. Second, I'm going to discuss about head trauma. So it used to believe that there was an association between preceding head trauma and the development of blepharospasms, but case control studies have disproved these, or haven't failed to prove this association. Smoking and coffee. So earlier studies thought that actually smoking had a protective effect for the development of blepharospasms. But however, this earlier study had not separated coffee consumption and smoking. So it is believed in a recent study that the protective effect is more from the coffee consumption than smoking. So we do not encourage to smoke to decrease the blepharospasm. More recently, a study conducted in Asia that it was an epidemiological study that included 1,300 patients, found some of the risk factors mentioned earlier, but they also found that Blepharospasm patients were involved in a higher level of urbanization, depends on the location where they live. They had a white-collar work and had at least sleep disorders. So they believe that these could also be potential risk factors for the development of the condition. So now we're going to switch. We discussed a little bit about risk factors, and now I'm going to talk about genetics. So there are two forms. One is sporadic, so it happens basically randomly. There's no association with a family member. But the other type would be a familial. So epidemiological studies looking into patients that have blepharospasm or like focal dystonias had found that they have, usually these patients have a relative that has either the same focal dystonia or a similar one. And this association had been found in 5 to 25% of the patient, which is more than what you expect in a general population. So it follows an autosomal dominant inheritance pattern with decreased penetrance. So what are the genes involved in the development of benign essential blepharospasms and other dystonias? I'm going to go briefly over the ones that have been most recently studied. The most common, or the one that we know the most, is about the TOR1A gene that is located in the chromosome 9. That is related to either monogenic or sporadic form of dystonia. So there are mutations that happens in those genes that are believed to lead to blepharospasms. So this gene codes for a protein that is present in the cell, in many cells, and those includes in this central nervous system. The problem is we haven't been able research have been able to demonstrate how this gene or its protein leads to the development of blepharospasm. Another gene is the brain-derived neurotrophic factor gene. One of the major mechanisms in dystonia is reduced inhibition of the motor system and increased plasticity, so increase in synaptic activity in the brain. So it is believed that this gene is involved in the synaptic plasticity. And this has been demonstrated by an increased plasticity in the hand representation area of the motor cortex, basically in the areas of the brain related to blepharospasm. Another gene is the apolipoprotein gene, and the apolipoproteins, their role is to transfer fat and cholesterol throughout cells in the body, including those in the brain or the central nervous system. So they are believed to be involved also in plasticity, in synaptic plasticity, and therefore in focal dystonias. There was a study conducted in Japan where carriers of mutations in this gene, a specific mutation, developed a focal dystonia 10 years earlier than those carrying a different kind of mutation. FAT1 gene also encodes for a transcription of other genes, including the TOR1A gene. But again, we do not know how that leads into the development of blepharospasm. And last, as Dr. Ondo was talking, the importance of dopamine. Mutations in the dopamine genes can lead, have been found in patients either with monogenic dystonia, and there has been an association of mutations in the dopamine receptor 5, it is increased in a cohort of patients in British, but not in a cohort of patients in the US or Germany or Italy. So the take-home message of these is there are multiple genes involved, and we still need to find out how they lead into the development of blepharospasm. So now we're going to look into neuroimaging, what findings had been reported. Originally, it was believed to be a disorder. Blepharospasm used to be a disorder of like the basal ganglia, a specific area of the brain. But recent studies have demonstrated that not only the basal ganglia is affected, but other parts of the brain. And this table summarizes some of the studies that have shown increase in the gray matter volume in certain parts of the brain, or decreased gray matter volume in certain parts of the brain. And I'm going to go over them briefly. So Black and collaborators and Edgerton collaborators found like a 10% increase in gray matter volume in patients with focal dystonia or patients with blepharospasms, and they compared to healthy age-matched control patients. But in contrast, other studies have found, instead of an increase, a decrease in gray matter volume in the putamen and thalamus, and an increase in gray matter volume in another part of the brain, in the caudate head and cerebellum. In contrast to those previous studies, Martino and collaborators found no changes in the basal ganglia, but the importance of this one is that they found changes in the cortex of the brain. There was an increased gray matter volume in the right middle frontal gyrus, decrease in the left postcentral gyrus, and left superior temporal gyrus. So the importance of the last study is not just the basal ganglia, it's also the cortex that is involved. And this figure summarizes the studies that I just mentioned. So what is important to note is these control studies, that these gray matter volume changes, that basically a very specific kind of MRI technique had shown that there are areas where there is decreased volume or increased volume. But these changes might be related to the sample size, might be related that the larger the sample, the larger the study that included more patients, the more likely you're going to find changes in the brain structures. Why some of the studies show increase and some of the studies show decrease in gray matter volume? It could be because in some of them, they didn't divide these patients as blepharospasms or any other different kind of dystonia. They lumped them together. Or sometimes it could be the severity or the age of onset or the use of botulinum toxin, severe, that can be affected or have conflicting results. So, other studies supporting the role of the cortex involvement in patient blepharospasms is by Horowitz and collaborators. And you can see, I'm not going to go over the details, but basically they also found a decrease in certain areas of the brain and an increase in other areas. And with the last study with Ramdani and collaborators, the important things of this is that they started to divide them in task-specific dystonia versus non-task-specific dystonia, and they found that patients with blepharospasms, the changes that they found were only limited to the cerebellum. I promise this is the last study. So with this neuroimaging study by Berman and collaborators, what they did is this time they divided patients, whether they have blepharospasm or cervical dystonia. So they separated them. And they found that there were specific changes or patterns of altered structures in the brain that were specific to blepharospasms or that were specific to cervical dystonia compared to healthy controls. They use also a very MRI study for these, and they basically found that it was a decrease in certain areas of the brain. You can see it highlighted in blue in patients with cervical dystonia compared to blepharospasms patients. And the changes that were decreasing in patients with blepharospasms were related to the severity of disease. So the conclusion about neuroimaging is that the most important conclusion is not just the basal ganglia is involved or is altered in patients with blepharospasms, but there are other areas of the brain as well. And that we do not know whether these changes precede or are a consequence of the condition. Now, functional studies. So it has been demonstrated that there's an increase in glucose metabolism in certain areas of the brain, such as the striatum and the thalamus in patients with blepharospasms. Interestingly, there's an increase in the glucose metabolism in the thalamus and pons in patients with blepharospasms, even after the injection of botulinum toxin. So the authors of this study believe that this is a compensatory mechanism. Also, the same group found that this metabolism is increased in patients with blepharospasms, but is not in patients who have drug-induced blepharospasms. That tells you that there's a difference between the mechanism for both of these groups. Hutchinson and collaborators found that during sleep there is a frontal and a part of the brain hypometabolism in the regions associated with blinking, but while the patients are awake, they are hypermetabolism. So there's more consumption of glucose in certain areas of the cerebellum in those patients. And there is a correlation of brain metabolism of glucose and the severity of disease or severity of blepharospasms. Other functional studies have looked into the dopamine, decreasing dopamine in patients with blepharospasm compared to healthy control, and that's why some of these drugs that were discussed earlier are targeting dopamine. Functional MRI studies have also found hyperactivations in the areas that are associated with blinking. And then this activation is even in patients' voluntary blinking is increased, this activation. However, in patients with blepharospasms, this hyperactivity is even higher or greater. So these authors believe that there is actually a hyperactive cortical circuit that is linking the visual cortex and other areas of the brain, as well as the periorbital muscles. So the pathophysiology of or how blepharospasms occur is still unknown. But the hallmark of the condition is that there is enhanced excitability of the blinking reflex due to lack of inhibition of the basal ganglia structures and other structures of the brain, as we discussed earlier. So how does blink occurs? So there is usually an afferent pathway, which is what brings the stimulus to the brain, an efferent pathway that brings the stimulus from the brain to the muscles and causes the blinking. This is carried by cranial nerve 5, and there is a connection between these two nerves, and the efferent pathway is carried by the facial nerve or cranial nerve 7. So in blepharospasm, what happens, or in dystonias, is that with a discrete movement, there is co-contraction of the antagonic muscle. So you have one muscle that it wants to open the eye, one muscle that wants to close the eye. So if you want to open, the antagonist with the closure will be activated and will lead to closure of the eye. So in a person, in a spontaneous blink, what we have is activation of the orbicularis, which is this muscle responsible for closing the eye, and there's a relaxation or inhibition of the levator muscle, which is the muscle, one of the muscles responsible for lifting the eyelid up. So with electromyography, which is a study that is used to record muscle activity, it has been demonstrated that patients with blepharospasm, there is an overactivity of the muscle that closes the eye, of the orbicularis muscle. However, we have not been able to evaluate really well the muscle that opens the eye, because as you can see in this picture, this muscle is deeper, it's not a superficial muscle. So usually the EMG or electromyography techniques are usually non-invasive. It cannot target that muscle. But in a study in the 1990s, using needle electrodes to target the muscle that opens the eyelid, show that maybe there is damage to that muscle. Maybe there is lack of inhibition of that muscle, and then the orbicularis keeps contracting. So what the take-home message from these is that it may not be only hyperactivity of the muscle that closes the eye, but maybe there's too much inhibition of the muscle that opens the eye. So how is the blinking assessed? It's assessed by a stimulation, electrical stimulation of the supraorbital nerve located in this area, and then there's a recording of the muscle activity. So when there's a study that compare healthy control subjects with patients with blepharospasms. So when you stimulated that nerve, it causes a response. And you can see it depicted here. So they do two stimulus. One stimulus separates shortly after another one. That is the conditioned stimulus and the test stimulus. So in normal patients or healthy patients, that conditioned stimulus does not, if you test the other stimulus right away, it will not lead you to acceptability of the blinking reflex. So you can see that how this wave is flat. If you space it out a little bit more, you still don't see much activity. You have to wait about 2 seconds in order to recover from that blinking stimulus in order to develop another one. But in patients with blepharospasms, you put the first stimulus and then it follows by another stimulus and you already have a response. So this is not abolished. So here, 2 milliseconds later, and the response even greater. So that's the main difference. So there's an increased hyperexcitability of the blinking reflex in patients with blepharospasm. But the trigeminal facial reflex is not the only blinking reflex. There's also the somatosensory blink reflex, in which blinking can be elicited when you stimulate other parts of the body, not just the supraorbital nerve or the cornea, the cornea, the surface of the eye. And this has been proven to be also enhanced or activated. There's much activation of that reflex in patients with blepharospasms. Similarly, the auditory stimulus means a reflex with stimulation of the hearing is exaggerating in patients with blepharospasms. And the visual stimuli also increases the contraction or the activity of the orbicularis muscle. And that's why, like tinted lenses that decreases that visual stimulus or that photophobia can also provide some comfort and decrease the force of the contraction of the eyelid muscles. So in summary, there are multiple risks in summary. The most important is we do not know very well what causes blepharospasms, that there are multiple risk factors involved, and we believe that there is a genetic component as well as an environmental component. The strongly associated risk factor for blepharospasm, the strongest, will be like anterior segment disease or eye disease. There are familial cases and sporadic cases. There are multiple genes involved, whether in sporadic cases or familial cases. How do those genes lead to blepharospasm? It's still unknown. Not only the basal ganglia is the area of the brain that is affected in patients with blepharospasms, there are other areas such as cerebellum and the cortex. And we do not know whether these changes that with conventional imaging, like a regular CT or MRI, we cannot see those changes. Otherwise, it will be a secondary blepharospasm. But those changes occur, and we don't know if it precedes the development of the condition. There is an increased excitability of the blinking reflex, and there's overactivity of the orbicularis muscle, or maybe there's a dysfunction of the levator muscle. There are too many questions to still answer to understand how blepharospasms occur. I think we have a later talk about the present and research future. I believe it is important to find out what the role of the eye disease is, and if maybe treating that will prevent it from developing the condition. Also, if we identify how the genes leads into the development of blepharospasm, it could be potential a therapeutic target. Thank you.